Thank you, everyone, for joining us for LHSC's March Community Update meeting. It's great to connect and share updates on important work happening across our organization. But before we begin today, I want to turn things over to Tanya Testa, who's LHSC's Vice President of Communications and Community Patient and Client Engagement.
Thank you, David. Good afternoon, everyone. I would like to begin by acknowledging that we are gathered today on the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and Attawandaron peoples. These lands are connected with the London Township and Sombre Treaties of 1796 and the Dish with One Spoon Covenant Wampum, which calls on us to share and care for the resources of this region in peace and friendship. Today, this region is home to many diverse First Nations, Inuit, and Métis people whose enduring presence and deep knowledge continue to shape this territory. In a time of global uncertainty and some division, these teachings remain deeply relevant. They call us to act with respect, to care for one another, and to work toward collective well-being, principles that are especially important in healthcare. As we live and work here, may we honor the original caretakers of this land, reflect on our responsibilities as treaty people, and commit to meaningful action in the care we provide and the relationships we build. Thank you.
Thank you, Tanya. So these meetings are an important opportunity to share what's happening across LHSC and to celebrate the work of our teams and how they impact and the impact they have on our patients, families, and communities. As always, these meetings are live streamed through YouTube and a recordings made available afterwards. Also, a great added feature is our meetings also replay regularly on Rogers TV London. So each month we highlight examples of how our staff, professional staff, leaders, learners, volunteers, and patient partners are improving care, advancing research, and supporting one another. These meetings are also a space for transparency and conversation, highlighting our progress and achievements, as well as discussing challenges and opportunities we might have. Once again, I really want to thank everyone who continues to join these sessions and staying engaged and looking at the work we're doing and engaged in the work we're doing. Your involvement is what makes a massive difference. This is what allows us to keep focused on matters that mean the most to individuals like yourself. So first thing I want to talk about today is an exciting world first innovation at LHSC that's directly improving patient care. Last fall, our neurosurgery team, led by Dr. Neil Dugal, became the first in the world to use a portable MRI during surgery to remove a complex pituitary tumor. For those of you who might not know, the pituitary gland is a pea-sized master gland located at the base of the brain. Tumors in this area can clearly cause headaches, vision changes, fatigue, and hormonal imbalance. Because of where the gland sits, these tumors are also surrounded by critical structures, including optic nerves and arteries. Even though with minimally invasive surgical techniques, confirming that a tumor has been completely removed can be very challenging. So during this procedure, the team used a portable MRI, directing in the operating room before completing the surgery. The real-time image allows the team to immediately see whether any tumor remains and safely remove it before finishing the operation. For the patient, clearly, that means greater confidence in the outcome, a reduced likelihood of needing a second surgery. So this precision and innovation in action is technology being used thoughtfully to improve safety outcomes and patient care. But innovation is just not about technology. It's about the people whose lives are being changed as a result of it. In this case, there was a patient by the name of Dave Evans who had been experiencing vision loss and severe headaches because of this particular issue. After surgery, David learned that the MRI allowed the team to confirm that there was still a small amount of the tumor remaining and safely removed it before completing the procedure. That additional imaging moved the result from about 90% removal closer to 99% removal. Today, Dave's doing well, his peripheral vision's returned, and his constant headaches that he once experienced are now gone. So it's a powerful reminder that innovation combined with the expertise of our teams can make a real difference for patients. Next item I want to talk about is supporting patient also means about the future of healthcare and people who one day will deliver that care. On March 12th, LHSC hosted our second Youth Indigenous Career Fair, welcoming approximately 110 students from 5 local high schools and the Namiring Friendship Centers and Wagash K Alternative Secondary School. The goal of the event was to give students the chance to explore the many different careers that exist in healthcare before they begin making decisions about post-secondary education. The atrium was filled with about 34 interactive booths from various departments at LHSC, and where our community partners, where students could meet healthcare professionals, learn about different roles, and try hands-on demonstrations. It was an opportunity for young people to ask questions, hear real career stories, and start imagining themselves in these spaces. The day began with an opening ceremony led by Elder Chris George from Oneida of the Thames First Nation, along with traditional singing and dancing by Amanda Docksader, a faith keeper from Oneida, of also the Thames First Nation. Events like this reflect our partnerships. We're continuing to build with the Indigenous communities across the region. They also speak to an important goal for future healthcare. Across Canada, First Nations, Métis, Inuit, urban Indigenous peoples remain underrepresented in many health professions, particularly in specialized care and in leadership roles. Further, they create pathways and opportunities for Indigenous youth to see themselves as future leaders, innovators, healers, and change makers within the healthcare system. When students can meet people working in these roles and see what's possible, it helps plant the seed for the next generation of healthcare professionals. These also are not possible without the support of our community partners. So I really want to thank Kyra Alick, our Youth Indigenous Patient Navigator at Children's Hospital, Lisa Jackson, our Indigenous Project Coordinator and Resource Consultant at Southwest Regional Cancer Program, and an organizing committee who made the Youth Indigenous Career Fair such a massive success. Now we move into presentations. That's why you're here. I'm going to hand things over to Deborah Wiseman, who's our Corporate Nursing Executive and Vice President of Medicine, Emergency Services, Critical Care, and Clinical Neurological Sciences, and Dr. Christy McDonald, who is our Interim Vice Chair of our Medical Advisory Committee, but also our Department Head for Emergency Medicine.
Thanks, David. And thank you all for joining us for this March Community Update meeting. I'm excited to be here with you today to share how LHSC is redefining hip fracture care and improving outcomes for older adults. A hip fracture, otherwise known as a broken hip, refers to a break in the upper part of the thigh bone, or what we call the femur, near the hip joint. These are often a result of falls, particularly in older adults, and more common in women due to faster bone density loss after menopause. Hip fractures are life-altering events. They can reduce independence, and they can sometimes shorten life. So how is LHSC helping? Dr. Jenny Thane, pictured here, specializes in osteoporosis and bone health, particularly with a focus on hip fractures. Dr. Thane is a well-known figure in hip fracture care and is actively involved in various initiatives, including her role as clinical lead for hip fracture at Ontario Health. At LHSC, under Dr. Thane's clinical leadership, we launched a dedicated hip fracture unit back in 2018. This unit integrates orthopedic surgery with geriatric medicine, bringing together the surgeons who repair the fractured hip with the geriatricians, physicians who focus on the healthcare of older adults. They address the complex medical, cognitive, and social needs to improve quality of health. This coordinated model ensures that patients receive timely surgery, proactive management of complications, rehabilitation planning, and an osteoporosis assessment to reduce the risk of future fractures. The goal is to enhance the patient recovery, improve patient outcomes, and the results have been significant. The team, working with this important coordinated model, reduced the risk of dying within 30 days by more than half. Rates of complications declined, and more patients were able to return home. Having recognized International Women's Day earlier this month, it's important to acknowledge both the leadership of physicians like Dr. Thane and the fact that hip fractures disproportionately affect older women, often due to the osteoporosis. Improving this model of care improves women's health and strengthens outcomes for all older adults. How can you reduce your risk of falls? Get enough vitamin D, keep active, particularly with weight-bearing exercises like walking and balance training, avoid smoking and excess drinking, and assess your home for hazards. Remove throw rugs, keep cords against the wall, make sure your rooms and passageways are well lit. And if you don't feel steady, ask a healthcare professional whether an aid, a cane, a walking stick, or a walker might help. I'm incredibly grateful for the hip fracture team and the positive impacts they're having for our patients. I'll now pass it over to Dr. Christy McDonald, who will share updates on rare diseases and research. Over to you, Christy.
Great. Thanks very much, Deborah. Thank you for the introduction. Now I would like to shift our focus to some of our youngest patients. Rare diseases affect more than 300 million people worldwide. Here in Canada, about 1 in 12 people is affected, and 70% of rare diseases begin in childhood. Most are genetic. Dr. Tucci Balci, a geneticist at LHSC and scientist at LHSCRI, is dedicated to helping families find answers sooner. Her work is deeply personal. She was inspired by her own sister, who had a rare disease and passed away at 8 years old without ever receiving a diagnosis. Today, she is committed to making sure other families receive the answers her own family never had. One of her young patients, Caden, was diagnosed with Kleefster syndrome after advanced genetic testing. That diagnosis gave his family clarity, direction, and access to appropriate care. A diagnosis certainly can be life-changing. It allows treatment to begin sooner, and in some conditions, it opens the door to gene-based therapies that can slow or even stop disease progression. But diagnosis is only the beginning. Dr. Balci is part of a team using advanced technology called EpiSign, developed here at LHSC by Dr. Bakim Sidikovic. EpiSign uses artificial intelligence to read what we call the epigenome, essentially a chemical layer that sits on top of DNA and controls how genes are turned on and off. This technology can now help diagnose more than 120 rare genetic conditions that were previously difficult to confirm. In some cases, diagnoses can now be made through a simple blood test. It allows physicians to give families clearer answers. It supports more accurate treatment planning, and it helps families make informed decisions about the future. Which leads us to the Southwestern Ontario Rare Disease Program, or SWORD, which was established with the goal to build a regional registry to better understand how families are affected, to identify gaps in care, and to increase access to clinical trials. As we mark International Women's Day earlier this month, it is important to recognize leaders like Dr. Balci, clinicians, researchers, and mothers who are advancing science while mentoring the next generation of women in medicine. In research laboratories at the London Health Sciences Centre Research Institute, Dr. Samuel Ashbaha and his team are challenging a long-standing scientific assumption. For many years, scientists once thought large parts of our DNA didn't do anything useful. The study focused on patients with inflammatory bowel disease, a condition where frequent immune-related injury damages the colonic lining, leading to ulcers and chronic inflammation. This repeated and persistent inflammation can significantly increase the risk of developing colorectal cancer. Scientists found that inflammation causes a response in cells that is normally reserved for fighting a viral infection. After further investigation, they found that this inflammation caused junk DNA to be activated, which produced an immune response that appears to prevent cancer. The research certainly is groundbreaking and found that inflammation triggered a response in cells that is typically used to fight viral infections. That response appears to help suppress tumor formation. When researchers turned off the ability of cells to mount that response in preclinical models cancer developed. This is early stage research, but it opens the door to understanding how we might one day harness the body's own immune mechanisms to prevent cancer in high-risk patients. It's a reminder that scientific progress often begins by questioning assumptions, and it is driven by the people who dedicate their careers to asking those questions. Frederica Larson, a postdoctoral associate working in Dr. Aspaha's lab, is studying how normal gut stem cells transform into cancer cells. Her work is focused on understanding the biological pathways that lead to tumor formation. This kind of foundational research is essential. Before we can change outcomes, we must first understand mechanisms. Frederica's journey from student to PhD to postdoctoral researcher reflects the strength of mentorship, collaboration, and growing female representation in science. Innovation in surgery, redesign in clinical care, discovery in research, leadership in science. Together, these efforts reflect how LHSC is advancing care today while building the knowledge that will shape tomorrow. I would now like to turn it over to Tanya Testa, VP of our Corporate Communications and Patient-Centered Strategy. So over to you, Tanya.
Thanks so much, Dr. McDonald. I'm really excited to share today's presentation space with Karen Connors, who is our Director of Patient Experience and Volunteer Services. Karen is going to share a little bit of information about how you can tell us about your experience at LHSC, whether it was at an outpatient clinic or you had an inpatient stay with us. We are excited to collect feedback from you, and we do that through our surveys. And Karen is going to share a little bit more about how we do that. Over to you, Karen. Thanks.
Thanks so much, Tanya. Good afternoon, everyone. It's a pleasure to be here. I want to talk to you a little bit today about patient experience and about our goals around informing a people-centered care approach at LHSC. Every day at LHSC, our clinical teams, our staff are talking to patients and families, our managers, directors, and VPs round often, and are hearing about the experiences of our patients. At LHSC, what's really important to us is that we don't just provide care to patients and families, we work and collaborate with them. And in patient experience, we have some particular responsibilities in that, and you'll see some of that in some of the slides that I will share with you. So for example, when you look, part of our role is very much about embedding the voice of patients and family partners in all the activities that we do here to help improve care. We really look at managing concerns about care in a fair and confidential manner through our patient relations process, and we track and learn from those patient feedback experiences about things that would help to improve care at LHSC. We also really ensure that all forms of patient and family feedback are used to improve that quality and safety of care. And in the picture on this slide, you can see what are some of the really critical and important touch points of the patient experience. Things like, are we providing culturally appropriate care? How is your care coordinated? Did you experience courtesy and respect? What was the access to care like? How was your communication? And did you get the information that you needed? Were you participating in that shared decision? And did you receive that self-managed support? We also then, when we're looking at patient experience, really think about what our promise is to you. And part of our promise is that we provide people-centered care, which means we focus on your specific needs, your values, and your goals. And within the Excellent Care for All Act, there is a requirement that all hospitals provide a way for patients to share concerns and give feedback, which we do have in place through our patient relations process. And we work to ensure that you and your family are partners in your healthcare. We want you to help support you in making decisions related to your care. And also, if you wish to engage in other ways, we welcome you to reach out to become patient and family partners, where you may be involved in hospital committees or other quality improvement efforts. Equally, we also share things like our quality improvement plan with the public so that you can know how we are working to get better. Today, I'd really like to take some time, though, to focus on our survey program that is run through the Patient Experience Program and is embedded across LHSC. So in this survey process, we really think about what is your feedback journey. And what I'd like to provide some information for you today is on actually who gets a survey. Right now, we have 9 ways to listen. So we have 9 surveys that are embedded in our programs, both inpatient and outpatient, and more surveys to come. We actually ask you on registration or on admission for an email address, and that email address is how we then share the survey out to you. It has a very personal touch, and David Moucher, our supervisor, has an email that goes out along with the survey explaining the survey process and how you can complete it. And it's available in both English and French. We also look at really respecting your time. So that means that you don't necessarily get a survey at each and every appointment that you come to LHSC. When you've completed a survey, say, for example, in an outpatient clinic appointment, then we won't send you another survey for at least 3 months. But if you happen to come back into hospital and go to the ED, for example, you could also receive that survey. And we ask people to complete those and so that we can receive your responses about what your experience of care was like. So you might wonder, do people really respond to the surveys and do we hear from them? And I can tell you that since April of 2025, over 49,000 people have shared their stories with us through the survey process. Through those surveys, we've heard that 78.4% of you felt that your overall experience of care was positive, and 38% of the patients who received a survey completed that survey. What does that mean? Well, one of the things that we know is that our response rate is quite high. Most surveys for patients have a response rate of about 10 to 15%. And here what we are finding is that we are hitting response rates of about 39%, which I think speaks to the fact that people really want to tell us about what their experience was like, the things that went well, the things that didn't go as well, and where we might be able to improve that. And one of the changes that's happened with surveys over the years is that they have become much more immediate in terms of getting results back to clinical teams. So right now, when someone completes a survey, we get the answers very quickly into a digital dashboard that's available for all of our area leaders to see. And so that's in real time. It's which is highly important. One of the things we're encouraging now that the dashboards are in place is for all of us to be looking at the dashboard to see what is it patients are saying when we're thinking about taking on a project, when we're wondering what patients and families might be saying about a particular aspect of care. During the course of the surveys, we've also at times received some questions about some of the items on the survey. And these we call socio-demographic questions. And these are questions that help us to learn a little bit more about individual patients, about things about their gender, their race, their ethnicity, their language. And sometimes we have heard from people that these questions can feel, particularly personal. They are certainly very optional, but they really give us great insight into the experience of care and really help us to better understand the needs of our community. Those surveys are anonymous, so it does not impact the care that you're receiving directly from your care team. So then what do we do with some of those, with the survey responses? And one of the places is that we really look at how do we make that be your voice in action. And last year, for example, we worked alongside patient and family partners to really help define what is the question that's important to patients in terms of our quality improvement plan. And what they highlighted was that there was the question that was really important was, did people have the information they needed after leaving hospital? If something were to change in their condition, what should they do? And we, the patient partners, helped to select that question. And over the last 2 years, we've been monitoring that question and reporting that question publicly. So our goal is to have patients feeling completely satisfied with their discharge information. And over the past year, we have seen a real shift in that. a lot of initiatives across the hospital to really help improve how people are answering that question. And our most recent scores show that we have improved by from prior about 63%, now up to 66.05% of being completely satisfied. And completely from the survey means 100%. So we also saw a real shift in people who were feeling more and more satisfied along that trajectory as we did the surveys. So these higher scores show that by listening to you and putting in efforts to really focus around that question, that our efforts can have an impact. What are some other ways that we put the you said and we did into action? One of the things that we heard both through the Community Advisory Council and the survey that they did, through our patient relations feedback survey, also through these surveys, is that people really wanted improved access to information and an easier way to find resources about the hospital. And so we created from that, as teams, we created new digital guides, and these really help move us from our paper handbook to a digital patient guide, both for our children's hospital and for our adult hospital. So the digital guides offer real-time information that can be updated quickly when things change. It also offers translation and works very well with tools that people who may need adaptation around vision can use the information and have better access. What we also know is we track the number of times that that's been used, and over a 3-month period, we know that 5,500 people accessed our digital patient guide. So that's another example of what are things that we're hearing from different ways, and then how do we actually use that to improve what's happening for our patients. Another project that we're involved in around our patient surveys is benchmarking. And what benchmarking means is, how do we compare to other hospitals that are also doing this same survey? And through that time, we have learned that that gives us an opportunity to compare LHSC to other hospitals. Through the comparison, we've heard some really great feedback, for example, around our children's hospital. We know that about 63.1% of the people who utilize services in our children's ED are expressing great satisfaction around that, which is comparison to 56% for other children's hospitals. The wait time was seen as above, as performing very well, and over 94% of the families in the surveys indicated that staff explained information very clearly. Another place that we've seen some improvements, and I won't go through each one of these metrics, but in our adult emergency care, we've seen over the recent months an 8.5% improvement in the overall patient rating of that experience of their care. And 5.4% expressed that when there was a wait, they received information about why the wait time was, and that was helpful to them. So these numbers show us that when you're completing your survey, we are actually using that information to guide quality improvement, and that is having an impact on patients when they come through in future. So the other place is, while we have 9 surveys in place in both inpatient and outpatient areas, we are also still looking to expand the surveys. And in the coming months, we are partnering with the Ontario Hospital Association to bring in 3 new surveys. And those are critical care satisfaction in our intensive care unit, our pediatric and youth inpatient program, and our pediatric and youth outpatient program. So that is simply another way that we will be expanding how our surveys are implemented across the organization and having opportunity available to more and more patients. So in the future, we know that good care is about how we communicate with you, how we help to make those ease of transitions throughout the hospital and and during your stay and your clinic appointments. It's very important to how you experience that care. It helps to build trust, and it's not just about the medicine and the treatment that we give. We also know that with our surveys that relying fully on email can be hard for some people, and we're looking at new ways to find the survey process so that others can also be involved. So when you often get a survey, I know I sometimes ask this question when I get one, I think, I wonder, does anyone ever look at it? What I can tell you is LHSC is very committed to reviewing the results of those surveys. We know you put effort into them, and then it's our responsibility to make sure we're putting effort into looking at them and listening to what you're telling us. So if you receive a survey, we truly would love to hear from you. I've also included there our email addresses if you need to reach out to patient relations if should you have a concern that you'd like to bring forward specifically. And also if you're interested in becoming a patient partner or learning more about our patient partner program, reach out to our patient engagement team. Thank you very much. Now I'd like to turn the screen over to Tammy Quigley, our VP of Cancer, Renal, Mental Health, and Patient Flow. Hi, Tammy.
Thanks so much, Karen, and hello, everyone. I have the pleasure today of introducing Dr. Michael Say, who is a gastroenterologist here in London. He's also our regional endoscopy lead for the Southwest Regional Cancer Program, along with being a preeminent researcher. And he does that research in the area of endoscopy. And we thought that since March is Colon Cancer Awareness Month, that we would take an opportunity to chat about a topic that sometimes we don't like to talk about in public. So we're going to get you a little bit more comfortable talking about our colons. So over to you, Dr. Say.
Perfect. Thank you so much, Tammy. And thank you for the opportunity to really promote colon cancer screening, because it really is such an important topic. So, you know, it kind of goes back to what Carrie is saying. Tammy mentioned in that our colon is not really something we really want to talk about, and poop and things like that. You know, it's often not things we broach in our social circles or even with our doctors. But nonetheless, I really do want to stress how important it is to get screened for colon cancer. And one of the most important reasons for this is because colon cancer is so common in Canada, and in fact, is the second leading cause of cancer-related deaths in our country. Now, the other problem with colon cancer is very often, especially when the cancer is very early on, you may not experience symptoms. And so if we don't experience symptoms, it may give us a false sense of security that we don't have colon cancer and that we don't need to be screened. But over the course of my talk, I'm going to hopefully convince you that, in fact, if you have no symptoms, we really want you to get screened. This is even more important and highlighted by the fact that if we can catch your colon cancer early on at a very early stage, you have a very good chance of surviving it and being cured of your colon cancer over 90%. But that really hinges on our ability to detect the colon cancer at an early stage, which often means you have no symptoms. So who should get screened? Well, in general, for most people, if you're considered to be average risk, then you should get screened between the ages of 50 to 74. If you're not sure if you're average risk or not, it's best to speak with your healthcare provider, typically your family doctor or your nurse practitioner. But in general, most people will be considered average risk if you don't have a first-degree relative with colon cancer. So that typically means your parents don't have colon cancer, your siblings don't have colon cancer, and to a certain extent, your children don't have colon cancer, although typically your risk of getting colon cancer goes up as you get older. But what if you're feeling well? Do you still need to get screened? Well, based on what I told you before, if you're feeling well, you're actually the perfect patient we want to go in to get screened. Now, if you do have a family history, if you have symptoms, then you should speak again to your family doctor or your nurse practitioner to sort out what is going on. So what is the colon cancer? What is the colon cancer check program, the CCC program? And this program is the provincial program for getting screened for colon cancer. It is administered by Ontario Health, and the main component of it is something called a fecal immunochemical test, or what we call FIT. This is basically what we also call the poop test, whereby it's basically a test to detect microscopic amounts of blood in the stool, because we know that when people get colon cancer, it can bleed, again, microscopically, in such small amounts that we can't see it with the naked eye, but we can detect it with a FIT. And this is the test that's recommended for people who are at average risk for colon cancer. The important thing to know for FIT is that it replaced the older test that we had before, which was much more cumbersome and difficult to do for the patient. And in fact, FIT is very easy now. Whereas in the past, you had to check multiple stool specimens, you had to change your diet, you had to change some of your medications. The new test is very easy. You don't have to change your diet, you don't have to change your medication. This test is painless. You can do it in the privacy of your own home, and you only have to do it with one stool specimen. Now, if your FIT is positive, then you do need a follow-up colonoscopy to see if you have colon cancer or not. When you get a FIT, basically a package will be sent to you. And in this package, you get a little container, which is at the bottom of the screen with the little green lid in it. And basically, all the instructions comes with it. It's available in different languages as well. And basically, when you are available, you go to the bathroom, you do your business, and basically you just get a little bit of poop with the collection container. When you open it up, the lid has a little brush in it. You put it in the poop, and then you put it in the container, and you mail it back to the lab. The envelope is prepaid, pre-addressed. You know, we've really gone out of our way to make it as easy as possible because we really want people to get tested. You can drop it off at your local Life Labs, and all of the instruction is in there, but I think for most people, it's probably easiest just to drop it off in the mailbox. So the first step, of course, is you have to get the test ordered, and in a few slides, I will explain to you how that's done. But basically, once you receive the kit, then again, it's very simple, painless. You just do your business, get a little bit of stool, send it to the lab. And again, no medication or dietary changes are necessary. After the test is done, there's two common test results. One is you have a normal test, and that basically means no blood was found. And again, we're talking about microscopic amounts of blood, and so you should have another test in 2 years. If it's an abnormal test, it means blood was detected, and it may be a sign of colon cancer, but it may not. And to sort this out, you really need to go on to have a colonoscopy, and typically the sooner the sooner the better. There are benchmarks set by the province in terms of how quickly it should be done, and it should be done within 56 days or 8 weeks. And oftentimes we do it even sooner than that. Whenever I engage with the public to promote colon cancer screening, a very common question I ask is always, "Hey doc, what symptoms should I be looking for?" And I always say, I'm happy to tell you, no problem. But really, I want to emphasize that we don't want to reach the point where you have symptoms. Okay, it's really important that even if you don't have symptoms, to still get screened. Now, below are some of the symptoms that you may experience. One of the most common one people think of is blood in the stool. The problem with seeing blood in the stool is that very often colon cancer, there is no visible blood. We can't see it with the naked eye. And so we don't want to not get tested until we have blood in the stool. And to be honest, if you have blood in the stool, if you can see it with your eyeballs, you should get a colonoscopy. You should not do a FIT because we already know you have blood in the stool and we don't need to confirm it with the FIT. Just go and get a colonoscopy. Changing bowel habits is something people think about. Oh, my bowels have changed recently and I'm not entirely sure why. It is, colon cancer can cause a change in bowel habits, but in my experience, most patients with colon cancer, oftentimes even advanced colon cancer, may not have a change in their bowel habits. And certainly we don't want to be reassured that everything is okay, that we don't need to be screened just because our bowel habits are unchanged. You can lose weight with colon cancer. Again, in my experience, oftentimes it's a very late sign. And when the cancer has unfortunately spread to other parts of the body before you start getting weight loss. And certainly we don't want to wait until so late in the disease process. We want to catch the patients when they have no symptoms whatsoever. This is Kate, one of our patients who was kind enough to share hers with us in terms of encouraging people to get colon cancer screening. And her colon cancer was actually found through FIT, but she had many tests before with the older versions of the test as well. And she had negative tests and no symptoms at all. But of course, in her case, her FIT came back positive. And this led to her getting a colonoscopy quickly, which detected a colon cancer at an early stage, well before she would have had symptoms. And this matters. Kate is a perfect example of why we do screening, because if she didn't do the FIT and we just waited for her to develop symptoms, it could have been many months or even a year or two before she has symptoms. And by that point, the cancer is typically much more advanced, and our ability to cure it and to treat it goes down by quite a bit. She's very grateful she did the test, and that in fact her colon cancer was caught early. And the last time I spoke with Kate, she's still doing very well. In Southwest Ontario, in terms of our catchment, this figure it's called a heat map, and it looks at the 1.25 million people living in the Southwest region and the uptake of colon cancer screening. And so if overall in our region, about 62% of people are up to date with their colon cancer screening. And so this is not unique to our region. This is actually on par with the rest of the province and around the world, that there is a significant portion of people who are behind on their colon cancer screening. And so we want to do better. We feel we can do better. And this is why we reach out to our media partners for help to get our message out. Things we've done in the past include community outreach initiative. We work with all of our regional hospitals, not just in LHSC. We meet regularly with other doctors and administrators and leaders to promote colon cancer screening. We do poster campaigns, particularly in March during Colon Cancer Awareness Month. And I always say we should put our promotion posters, don't put it in the endoscopy unit, don't put it in the gastroenterology clinic, because when you're seeing a gastroenterologist, we're thinking about colon cancer for you, right? We want people to think about colon cancer when they are not thinking about it at all. So I say put it in the cafeteria, put it in the emergency room, put it in the blood lab. You know, this is where we want to raise the issue of colon cancer screening. Now, sometimes getting screened is difficult because we know a lot of our community members don't have primary care access. They don't have family doctors and nurse practitioners. And so I will share with you in a few slides how everyone can get access, even if you don't have primary care provided directly. We're always open to ideas. If you have any ideas at all, please let us know. I've posted our email there. We're always happy to work with people to get our message out. In terms of getting a fit, so again, if you do have a primary care provider, then simply ask them. If you don't have one, then you can actually call Health Connect Ontario. You just dial 811, and then there is a process that's set up that will get the kit to you and have a doctor review the results for you and get you the colonoscopy if necessary. So what's the key takeaway? Get tested. If you're in the age group, if you don't have a first-degree relative with colon cancer, then do the FIT. If you do have symptoms, if you do have a first-degree relative, then talk to your healthcare provider about whether colonoscopy is a better option for you. Don't be scared of the FIT. It's free, it's simple, it's life-saving. Even though we don't talk about it with our friends, we know every year tens of thousands of Ontarians are getting screened with FIT, okay? So everyone's doing it. Well, not everyone. Many people are doing it, so don't miss out. Don't wait for symptoms. I think that's my message to everyone. So next, I'm going to hand it over to Jerry Plastino. He is a VP Surgery, Cardiac, Transplant, Medical Imaging, and Biomedical Engineering. Thank you.
Thank you, Dr. Say. Very important message. And hi, everybody. Thank you for joining us today. We really do appreciate you taking the time to be here. And I know that surgical wait times are a concern for many people in our community. And my goal today is to really just share where things stand, what progress LHSC is making to improve our surgical wait lists, and what we're doing to help patients ensure that they receive their operations within the recommended wait time. I'm going to start with a quick overview of how surgical wait lists work in Ontario, and then I'll walk you through our results and the steps that we're taking to keep improving. So, what is a surgical wait list? It is simply a list of people who need surgery and are waiting for their turn. Typically, you or your surgeon will decide that surgery is the right plan for you, and then your name is added to the list. The most urgent cases are scheduled first, while others will wait based on medical need rather than the order that they're received. The wait list does help the hospital plan for our operating rooms, staffing, and equipment, with the goal of getting people surgery as safely and as quickly as possible. And if you're curious, Ontario Health does have a public wait times website where you can see your estimated wait time by procedure and how all hospitals compare to the provincial average. So let's talk about wait times. And the province does measure them in two parts. First, there's something called wait 1. This is the time from when a referral is sent from your family physician to when you see the surgeon for the first appointment. Next is the wait 2. This is the time for when the surgeon decides surgery is needed to the day of the actual surgery. And that's what we're focusing on here today. Patients are assigned a priority level based on symptoms and urgency using a standard assessment tool. That's what drives the target timelines you see here. The more urgent the need, the shorter the recommended wait time. When we talk about scheduled surgeries or elective surgeries, these are these wait 2 targets, and they do differ across the surgical categories. And that's going to be cancer, non-cancer, and cardiac. Ontario Health establishes these wait times for various procedures. Shorter for urgent surgeries like cancer or cardiac, but sometimes you could wait up to 6 months for surgeries such as a hip or knee replacement. It's really important to note that there is variability in these wait times across all the different surgical specialties, and it is dependent on the type of surgery you may be receiving. One thing I do want to acknowledge too is that we perform a high volume of emergent surgeries as the tertiary quaternary center for the region. We've performed almost 8,000 surgeries, emergent surgeries this year. And when a surgeon classifies a surgery as emergent, it receives our top priority. And depending on the specific circumstances, that surgery could be performed anywhere from a couple of hours to a couple of days. So with that context, let's talk about surgical volumes and wait times before and after the pandemic. As many of you may know, hospitals across Ontario, LHSC was similar and it had to pause many non-urgent surgeries during COVID-19, and that created a backlog. The good news is our surgical volumes have recovered and wait times are improving. So far this year in 25-26, LHSC has performed over 28,000 surgeries. 75% of those are elective surgeries and are being completed within the targeted wait times. And you can see that wait times are improving, decreasing from 309 days during the height of the pandemic in 2020 to 2021 to 193 days currently. I do want to acknowledge this doesn't mean everyone's experience is the same. Some people are going to wait less, some will wait longer, but it's a clear sign that we're moving in the right direction. Next, let's touch upon cardiac surgery because LHSC serves a broad region and those volumes remain a priority for us. So this year, we're expected to perform over 1,200 cardiac surgeries with 82% of those cardiac surgeries being completed within the target wait times. And this is specifically for the cardiac surgery known as CABG, or which is also known as the coronary artery bypass graft, where our average wait time is 56 days. Another thing to note here, which is important, is that our cardiac surgical wait times pertains only to a single category of cardiac surgery. And this particular wait time does not offer a complete perspective on all overall wait times for cardiac surgical procedures. Next, we're going to talk about the size of the overall surgical wait list, because I know that's a number that many people understandably want to focus on. So how big is the surgical wait list at LHSC? This next slide here shows a simple point in time looking at the total number of open surgical cases. Before the pandemic in 2019, there was 6,777 open cases. During the pandemic, that list rose, reaching 6,913 at its highest point in 2020-2021. As of this past February, we've decreased that wait list and are now at just over 5,500 open or active cases, which means the team here at LHSC has reduced the number of patients waiting by 19% compared to our pre-pandemic levels. And that improvement didn't happen by accident. It's come from focused work, adding operating room time for priority areas like cancer, brain, spine, and pediatric cases. and doing the important behind the scenes work, cleaning up the wait list so it's accurate and removing duplicates or making sure that the information is current. So how did we do that? We reduced the wait list by increasing surgical capacity. Since 2023-24, LHSC has added an average of 2,000 operating room hours across our Victoria, Children's, and University hospitals. We've received additional funding from the Ministry of Health to do more children's surgeries, more brain and spine surgeries, and more cardiac surgery, as well as training more operating room nurses and support staff because staffing is a key constraint. And this leads me now to the longer-term piece of our solution, creating more space for the right kinds of surgeries in the right settings. And one of our biggest long-term initiatives is to expand surgical capacity at the Nazem Kadri Surgical Center, which is located on Baseline Road across the street from our Victoria Hospital campus. The plan here is to increase from 2 to 6 operating rooms for day surgeries, bringing the total operating rooms at LHSC to 39. You may not know this, but LHSC has one of the largest surgical footprints in the province, and this will only add to it. What this does in plain terms is we'll move lower complexity surgeries into a dedicated space, and that frees up space at our main campuses for surgeries that could only be done there, like our complex spine, like our cancer cases, or cardiac, neurosurgery, and children's surgeries. So, what does this mean for our patients and families? Here's the bottom line. We expect our patients and their community and their family members to receive shorter waits for many surgeries, more surgeries done on time, fewer cancellations, and better access for children and people with serious conditions. The core message is this: we're doing more surgeries, training more staff, and adding more space, using new funding to reduce wait times for our community. If you're waiting right now, we know that it's stressful. We're committed to continuing this work. Thank you to our teams who are driving this progress, and thank you to the community for your patience and support. And now I'm going to pass things off to Narissa Taylor, our manager for virtual care, who's going to discuss how patients can access their personal health information through our MyCarePortal. Thank you.
Thank you, Jerry. Hello, everyone. I'm Narissa Taylor. I'm the manager for the virtual care program and MyCarePortal. And today I'm thrilled to announce the launch of our very own patient portal called MyCarePortal, how it can help patients, and how LHSC patients can request access as of Tuesday next week. So what is MyCarePortal? This is a secure and free, accessible, web-based and app-based solution. It allows patients to log in and you can view your medical information and upcoming appointments from your electronic health record. It is a regional portal, as in all records that will be in there will be available from all regional and participating hospitals that share our electronic health record. We also used a patient co-design framework to help with the promotional material design decisions, website designing content, and patient-facing information, as well as the branding and logo. And we know that MyCarePortal will facilitate patients' access to their personal health information. MyCarePortal is the largest Oracle patient portal implementation in Canada. London Health Sciences Centre, if you didn't know, we do share an electronic health record with 14 other hospital sites in the southwestern Ontario region. So if you have a MyCarePortal account and you are a patient of any of the participating hospitals on this slide, you only need to log into one place to access your healthcare information for free. MyCarePortal enrollment began with those regional Southwestern Ontario hospital partners in September 2025, and so far we have 6,300 patients enrolled to date. For some of you, this may be a new concept, logging in and seeing your test results online, and for others, you may have already experienced some of these benefits. Having access to your personal health information can help to understand your health and medical conditions. It can help with medication adherence, that is, taking medications as prescribed by your doctor or healthcare professional. It can help improve the trust between the patients and the clinician. It can help with understanding the healthcare plan, what's coming next, and why you're doing certain tests. And it can also help with preparing you for your upcoming appointments and having questions that you wanted to ask at those appointments. We are already receiving very positive feedback from enrolled MyCarePortal users to date, and seeing real-world examples of how patients having access to their information online can help with expediting their surgery or obtaining a prescription over the holidays based on a test result. We are seeing a lot of really positive feedback about how easy the portal is to use for those who may be a bit edgy or not totally sure about the technology piece. It does seem to be very easy for people to use. In terms of what is available in MyCarePortal, if you log in, you'd have access to all results, all testing results once they're finalized. That includes imaging reports, general labs, pathology, and microbiology tests. There are just a few exceptions that are listed on the right. And discharge summaries are also available, as well as discharge educational material. So the ones on the right there are the ones that are included. So if you, just to note, you don't have access at this time to other clinical notes or consultative notes, that will be coming in the future. And patients can also view upcoming appointments and patient educational material, as well as surgical family histories that they report to their healthcare professional and their current medications from their most recent appointment. MyCarePortal is also an interactive portal. So as we start this portal, it is just for viewing information. However, in the future, there are interactive features we will look to be layering on. So as I mentioned, the enrollment for patients at this time is only for patients age 16 and older. So we do look to layer in pediatric functionality for enrollment, as well as shared access users, which would be trusted individuals that the patient would like to grant access to their healthcare record. We also want to increase the scope and availability of other clinical notes. And then there's interactive features like messaging features with your care team, managing your appointments, rescheduling or requesting to cancel appointments on the portal, and as ability to fill out electronic clipboards online. Now I'm going to show you a video of what to expect when you log into MyCarePortal, and here's some experiences from our patient co-design partners. Is a free accessible solution. Anyone who has a health record with our One Chart hospitals can log in, and you can see your test results, your imaging reports, discharge summaries, upcoming appointments, and a lot more healthcare information.
You need to be responsible for your healthcare information, and if you don't advocate for yourself, it could be life-altering.
It's our information, so we should definitely have access, and we should have access to that information as quickly as we can possibly get the information.
Now I can bring it up on my phone, or if I'm outside of the London area, whether I'm in Vancouver, Scotland, or wherever.
Patients are better prepared for their appointments. They have questions in relation to their results that they're often prepared to ask at the time of the appointment.
It's very easy to enroll. I am not a computer savvy person, and I was able to do it on my first go.
Arranging your appointments, getting your lab results, and all that sort of thing. I would really encourage people to do it.
You're playing a role in your healthcare. The portal is important. It's your own information. You can control it. You can take it with you.
If you have a patient record within One Chart, and it is also free, and I would encourage anyone interested to sign up. So at this point, you may be asking yourself, how can I enroll? Keep this date in mind, March 24th. That's next Tuesday. MyCarePortal will be available in a few different ways at LHSC. So if you're coming in for an outpatient visit, this will be offered during your registration, starting at University Hospital on March 24th, and then Victorian Children's Hospital for 16 and older will be starting on April 8th. There will also be an online or virtual enrollment option starting next Tuesday. If you navigate to the MyCarePortal website, you can request online enrollment. And we will have enrollment booths. I'm just sharing the t-shirt. So look for people with this t-shirt on at entrance points within both University Hospital and Victoria Hospital. And they will be able to also enroll you at those high traffic areas. So I did just want to take a moment to thank the MyCarePortal patient co-design team who are pictured, some of them are pictured in this photo, for all their efforts to getting us to this launch date. And the QR code also shows the MyCarePortal website. It is also simple. It is mycareportal.ca. So you can absolutely go there and see further information. Thank you, and I will turn it over to David.
Thank you, Narissa, for sharing the overview of MyCarePortal. That's going to be a big day next Tuesday for people to sign up. Pretty exciting, as you can tell from our patient partners who have already signed up, and we're able to kick the tires, and a lot of excitement there. So before we close, I want to remind everyone we have a web form available for you to submit any questions you have to be answered at this meeting. Since our February session, we didn't have any additional ones. But again, please use that if you wish to. Clearly, we really appreciate your engagement and encourage you to continue submitting any questions you may have. They help us address topics that are of interest to you and will clearly push us in the right direction in future community updates. So really want to thank all the presenters today. Some pretty exciting stuff. So again, thank you for tuning in. To our media partners, please join us in our media scrum, and we look forward to answering any questions they might have. So again, thank you, everybody. Have a great March.